How's it going, everybody? It's the CDH Warrior, and
Happy Monday, folks. This is the CDH Dad. Welcome to another Mondays on Mondays. Uh, in today's topic, we're basically going to be talking about just some reasons for our goal and efforts to try and raise CDH awareness. So we'll get into the details of that. But first of all, let's explain that we are not medical professionals. We don't have a medical background, a psychological background, a sociological background, but we do have several decades of experience in congenital diaphragmatic hernia, and then also in relation to our family, two children with special needs, both requiring some fairly extensive medical treatment. And part of what we're looking at is not necessarily all of the medical details involved with that, but just how it deals with the family dynamic and where it goes from there. So, thank you very much for joining us.
with that, let's roll the title.
Okay, welcome back, folks. Uh, we were just discussing exactly how we're doing our cast and streaming, and it's basically in two segments. We do a Mondays on Mondays, which is basically the two of us kind of discussing the family dynamic. Part of it right now is centered more on CDH, and as we said, with the family dynamic of having children with special problems. Uh, on Thursdays,
I do a series called CDH We Survived This, Now What? Which kind of goes over, okay, I'm almost 30. I'm one of the oldest CDH survivors. I'm not the oldest, because I know there are several that are in their late 30s, early 40s, and all the way up to 70. But they're few and far between. So I want to talk about uh, what the difference is as we get older, and kind of bring the focus back to we're not just cute little infants anymore.
now I'm not going to comment on that one, but no, just again trying to tie in that when we talk about the long-term survival, particularly on the CDH, with our experience at the time frame of his birth, survival rate was somewhere in 30 to 50% opportunity, chance of survival. So it was limited up until that time, and past that time, it has improved. Latest statistics I just saw where there's a 70 to 80% chance of survival now. Part of that is some of the protocols that were just being introduced in the mid 1990s when he was born, which helped lead to some of that improvement. But we still don't know some of the long term effects and the issues there. But part of, I know from our experience, was one of when he was born, we had no prior knowledge of CDH. A lot has improved in the prenatal testing and detection. I think I've discussed in previous times that we went through amniocentesis, we did the ultrasounds, we did fairly extensive testing pre-birth just to see if there were any issues or concerns. The doctors saw some things that raised some curiosity, but nothing that really piqued an interest to say, we've got a problem long term. We didn't know until right at the point of birth, and actually when my wife was in labor, that the heart rate was causing problems and that there was something going on. At first, the thought was that there was a cord wrap or something like that. It wasn't until after they did a cesarean that they actually determined that it was CDH. And one of the things that came up, like I said, I've got some notes to talk on, but is that children that are typically born normal birth have lungs the size of a baseball. Children born with CDH, because of the hole in the diaphragm, the organs being up in the chest, can affect the growth and development of the lungs, and they may have a lung the size of a penny,
Yeah.
and much less lung capacity. So part of what has evolved over a period of time has been more looking.
Can
Go
I
ahead.
jump in? I want to jump in because we just finished March of Dimes at work, and one of the things that it came, one of our displays for it was talking about premature birth and lungs the size of a penny. But I want to stress that CDH is not necessarily prematurity. They can be mutually exclusive.
Right. I mean, you were pretty much a full term.
Yeah.
And what we later surmised from what we found was that your hernia in the diaphragm was probably more later in development, but it did restrict particularly one lung,
Yeah.
just because of where the organs were in the chest. One of the things I did bring up, and I wanted to get in, is because CDH is not that well known and not that well recognized as a birth defect and a difficulty with childbirth. Yeah. But it occurs on the same rate as cystic fibrosis and spina bifida, which are fairly well known. And statistically, it's about a 1 in 3 to 4,000 chance that a child will be born with CDH. So basically, if you look at the numbers, every day 4 families are finding out that they've got a child with CDH.
Yeah.
Part of the reason we wanted to work on the improvement of the awareness of this, and in our case, we were fortunate in the fact that the OBGYN that performed the childbirth in our case had studied under Dr. K's at the time that he was just in the beginning phases
of his practice,
of his protocol at Shands Hospital in Florida. He has since moved to another hospital. But what got my attention was an item that I'd gotten through one of the CDH groups of a family that was diagnosed with a CDH child in Atlanta, a large city, multiple hospitals. You would expect something available in that case.
And they don't have a CDH hospital.
Part of what they brought up is they really did not have a place to deliver or treat that child. They ended up having to go to Florida and go to the hospital with Dr. K's. And when they talked with the doctors in Atlanta, basically 40-50% chance of survival. If they're lucky, maybe a 60% chance of survival. Yeah. Dr. K's typically has a 90+% success of survival. Part of this is working on a more centralized, multidisciplinary program. Yeah. At the time that my son was born, a CDH was basically came, the OBGYN would deliver the child, then they would send to a pediatric surgery center. The surgeons would do surgery and pass that child along to a NICU unit, the higher level NICU unit, and hope, okay, they may make it, they may not. And that was basically the prognosis I got. To give you a general timeline, birth was about 1:30 in the afternoon. Because we were fortunate and there happened to be a transport unit on the site where we delivered, actually to pick up another child, but they chose to take my son. he was transferred to a children's hospital which had pediatric surgery capabilities, but did not have the ECMO, did not have the NICU capabilities to handle the after treatment that may be required from that. So, born at 1:30, by the time I could get together and drive the couple of hours over to see that, I was there mid-evening. Surgery had already taken place. He was basically sedated and recovering. And at 2 o'clock in the morning, I was awakened, sleeping in a conference room in the hospital, which I found a place just to sleep. And for those of you that are parents, will know that you have to learn to adapt to the situations and places you are. In our case, it was one did not know anything that was going on ahead of time, so everything was kind of put it together as we go. But at 2 o'clock in the morning, I was awakened and told that he was going to be transferred to another hospital in Gainesville, which had the capabilities to do the further treatment. They had an ECMO unit. They had a higher level NICU unit. They had Dr. Case, who was working on the CDH protocols at that point in time. So this is where I'm seeing some of the issues that I wanted to address today, is that some of the data that I'm seeing, I will go back through some of the research and items that I can find.
Yeah.
Is the original idea of the protocol was it would be a hub spoke type protocol. It was being developed at Shands, and I think a couple of other hospitals were developing the protocol at that time, which was, let's not do the surgery immediately. Let's see if we can stabilize the child, take care of the pulmonary issues, make sure that they can have oxygen. We can take care of tube feeding. We can do the basic support, life support, and then determine if this child is ready to be able to handle the stress of surgery.
Yeah.
So those are some of the long-term things that...
To put this in perspective, the original protocol prior to Dr. K's was, we do surgery first and then pray and hope that things work.
Right. And now it's focusing more towards multidisciplinary. You've got, ahead of time, so your OBGYN can work with the pediatric surgery group and understand what is going on. They can work with a ECMO available children's hospital, which has the capability to provide the support there. But then you're also going to need to have neonatologists involved. You really need to have pulmonologists involved. In some cases, you're going to have to deal with a gastroenterologist that is involved. You may have to have a cardiac pediatric surgeon involved. And I still remember, this was prior to your birth, but you have a great uncle who's a pediatric surgeon and, pediatric cardio surgeon.
Yeah.
And his explanation, he says, okay, learning heart surgery is difficult, but imagine learning heart surgery on a heart the size of your thumb.
Yeah.
So you have to think about, you've got to have some highly specialized people involved in this care system and have them available if it's necessary. And there are other hospitals available. Shands Hospital in Gainesville no longer does this, but All Children's is now handling that. That's where Dr. Case has gone. CHOP, Children's Hospital of Philadelphia has that capability.
Although Pittsburgh does have a children's hospital that has a CDH.
Okay.
I'll just point out, so I live in Knoxville, and right now I can name off, there are 5 off the top of my head, 6 off the top of my head that I can come up with that are CDH related. Libonaire in Memphis, Vanderbilt Children's in Nashville, UVA, I believe it's UVA, Duke,
University of Virginia.
University of Virginia.
Yeah.
Duke in North Carolina. I think University of South Carolina, and then UAB, University of Alabama, Birmingham. Now consider that. That's 6. Well, if we want to get technical, Emory counts. But it's 7 hospitals. None of them are really close, although that's what? The closest is Vanderbilt, that's 3 hours.
Right. So, this presents difficulties for families having to deal with children. So some of the things we're going to want to address as we go through this is in our particular case, I was in my mid-30s when my son was born. So a little bit more uh, experienced and mature, a little more settled in some ways. I'd been married 10 years, so the marriage was able to handle some of these issues and go through it. And this was our first child, so we didn't have to worry about how to deal with another child in this experience.
Yeah.
We did have that instance with my daughter because I've discussed this previously, but she developed aplastic anemia. She's 2 years younger, and she developed aplastic anemia before she was 2 years old. So you were about 3.5.
I was 3.5 or 4.
At that point in time. So then we're having to deal with, okay, how do we deal with that child and their treatment and a son that has special needs, has progressed, but still needs some support and capabilities there. Fortunately, we were able to utilize grandparents who could help take care during that time period, and we were months in the hospital with her. So we can understand some of that stress and difficulty there. As I've brought out previously, this is not one of trying to go through statistics and the medical issues and those type of things. Part of what we're wanting to do in this series that we're working on is decades of experience in these type situations, and what can we do to help people better understand what to expect in the long term. And as I've brought out, part of what we really appreciate is the fact of the prenatal care has developed to the point where I think usually by 25 to 30 weeks now, most of the CDH patients have been identified in the U.S. So
now, there are exceptions. My case would not have been identified at all because mine was after what most people consider the threshold. But it's one, there are a few cases that will slip through, but for the most part, most of them are identified.
Right. Whereas in our case, it was fairly common that this was not identified until childbirth, and that's, you come into an emergency fire situation, and everyone is trying to put everything together, and unless you have a facility and the staff in place that understands what to do and has the capability to know what exercises need to be put in place, it makes it that much more stressful. So there are advantages to dealing with that ahead of time. But as I kind of said, the original idea was a few hospitals in the 90s were developing the protocol along this line with the expectation that that would spread out to other hospitals and other capabilities. But I think many parents at this point are still realizing that it's difficult to find a high-level NICU, neonatal intensive care unit, available near where you live, even if you live in a bigger city.
Oh yeah.
Much less in a small town somewhere in a rural area. But it's also difficult to find a children's hospital with a high-level NICU that also has ECMO capability. And we were just discussing this morning is that with ECMO, and I just saw a notice that there's a recall on some ECMO units at this point, is in the protocol needs to be that you have at least 2 units And one needs to be operational at all times as a backup. If one's in service, there needs to be an operational backup, because if you have a failure, there is no time to spend an hour trying to get something fixed.
Yeah.
You've got to go into motion very quickly. So this is where you work on that multidisciplinary. You've got respiratory therapists that are working in this. You've got neonatal intensive care nurses that are involved in this.
And I want to jump in and point something else out, since you brought up ECMO. There is an ECMO unit here in Knoxville, but it's at UT.
Yeah, it's at
University of Tennessee.
a medical center, which really doesn't have the pediatric capabilities to do that. So
but the thing is, you have Children's up the road, which does have the pediatric capabilities,
but they don't have the ECMO unit. So that's where some of these come into play. So part of what we're trying to do right now is just kind of work on raising this awareness, getting some word out there. In our discussions of what we're talking about is, on Mondays, I'm going to be talking about life, family, how you handle the job, the stress, a lot of those other things. So feel free to contact us.
Yeah.
You can do that either in comments on the video pages, or we also have an email address, which is Mondays on Monday4@gmail.com, and that'll be somewhere in the post when we put this in. But this is just, as I said, once a week, that's what I'm going to deal with. And then on Thursdays will be a firsthand.
I take over and give a firsthand experience of day-to-day life with CDH.
Right. And
right now, all I'm doing is just kind of giving you an overview. But over the next few weeks, we're going to get. We're going system by system, and then after that, we're going to go through and just talk about everyday life in general with CDH.
Right, and I think you're going to go through kind of an anatomy lesson. First step is the pulmonary function, getting the lungs working, making sure you've got breathing capabilities. Second phase is checking the cardiac and making sure that the heart, the blood vessels, those things are in place, because when the organs go in, that means the blood vessels aren't necessarily in the places you might expect those blood vessels. Then the next part is the major organs, the stomach, the intestines, the GI tract. What is going on there? Because this has been all over the place. In our case, it required significant resection because of damage that was caused. But then you've got the liver, the spleen, the kidneys, other organs that can be impacted from that. Then you get into the longer term issues, such as neurological issues. ECMO means that you are on a blood thinner, which means there's a capability of
possibility of
having bleeding,
thin blood vessel walls as well. That's actually quite common.
Right, and some bleeding in the brain is an issue that needs to be watched. But then issues with neuromuscular issues, skeletal issues, scoliosis, neurological. We haven't really looked at the details of how many have seizure disorders over the long term.
Interestingly enough, I was looking up, and I'll have to come back and find the statistic and post it, but there was a statistic about the incidence of ADHD and autism and ADD and CDH. There was a whole study done on this from NIH, and I'll have to find the link and post that in the comments of the video.
Okay. But anyway, I think we pretty much covered what we wanted to cover today. Thank you very much for your attention and following along with us. Hopefully you can tell others who may be impacted by CDH or special needs child issues about what we're discussing. Once again, we're not doing this from a medical perspective. We don't have the medical background. We don't have the psychiatric, psychological, or sociological background, but we do have life experiences to share. So we appreciate that very much. Thank you.
Have a great day.